Hey, hello, everyone. Thank you for joining us today. Welcome to our ATS Thoracic Oncology Assembly webinar, Lung Cancer Screening Incidental Findings. I'm Kathleen Capaccione, a member of the ATS TOA Early Career Professionals Working Group and Assistant Professor of Radiology at Columbia University. And I'm joined by Dr. Roger Kim, Assistant Professor of Medicine at the University of Pennsylvania, and Dr. Rebecca Scalabrino, a cardiothoracic radiologist at Memorial Sloan Kettering Cancer Center. Together, we'll be moderating today's discussion. Before we get started, we just wanted to remind everyone that this is a live event which will be recorded and uploaded to the TO Assembly website afterwards. If you have any questions throughout the webinar, please place them in the chat and we'll try to address as many as we can at the end of our time together. As a reminder, the views expressed during this webinar are those of the speakers alone and not necessarily endorsed by the ATS.
Okay, I'm very excited to introduce our lung cancer screening expert panelists who recently co-led the ATS research statement published in the Blue Journal entitled Lung Cancer Screening and Incidental Findings, a Research Agenda. They represent some of the world's leaders in the field, and we are honored that they have agreed to participate in this webinar today. Dr. Louise Henderson is the Director of Epidemiology Research, co-leader of the Lineberger Cancer Epidemiology Research Program, and Professor of Radiology Research at the University of North Carolina School of Medicine. Welcome, Dr. Henderson. Dr. Patricia Rivera is a C. Jane Davis and C. Robert Davis Distinguished Professor in Pulmonary Medicine and the Chief of the Pulmonary and Critical Care Medicine Division at the University of Rochester Medical Center and the immediate past president of the ATS. Thank you so much for being here, Dr. Rivera.
Thank you.
And last but not least, we're joined by Dr. Lynn Tanoue, who is the Vice Chair for Clinical Affairs and Internal Medicine, Director of the Lung Cancer Screening Program, and Professor of Medicine at Yale University School of Medicine. Welcome, Dr. Tanoue. So before we dive into our discussion topics, Dr. Kim will provide us a high-level overview of what was covered in the recently published research statement on lung cancer screening incidental findings.
All right. So as Dr. Capaccione and Dr. Scalabrino just mentioned, we're going to be really focusing most of our webinar today on this recently published official ATS research statement on lung cancer screening and incidental findings that was led by our expert panelists. As a reminder, this is a research statement meant to kind of guide which questions the panelists included on this research statement found to be most important to move the field forward and not meant to be a clinical practice guideline. So the research statement really ended up dividing the different questions and topics into three major areas. So the first was really the variability and the need for standardization on reporting incidental findings. And so some of the questions that were addressed in this research statement were, what is the very definition of a quote unquote significant incidental finding, which I'll abbreviate as IF in the subsequent slides here. There was discussion about expected versus unexpected incidental findings, the awareness of and generalizability of the already published American College of Radiology white paper recommendations for incidental findings, and then likely multi-level factors contributing to the variability in incidental finding reporting. The next topic that was tackled by the research statement was on the management of incidental findings. So this encompassed discussion about the benefits versus harms of managing and treating incidental findings found on lung cancer screening, downstream clinical consequences of incidental finding management, limited data on clinician and patient attitudes, beliefs, and preferences on incidental finding management, and the lack of standardized mechanisms for reporting and tracking lung cancer screening incidental findings at a system level. And then lastly, there was specific attention paid to identification and reporting of coronary artery calcification on low-dose CT that is sometimes found on lung cancer screening. And this discussion really centered around some of the technical aspects. So gated versus non-gated low-dose CT imaging for coronary artery calcification assessment, reliable application of current CAC scoring systems for lung cancer screening, And then again, that concept of expected versus unexpected coronary artery calcification in a heavy smoking population that is currently eligible for even receiving lung cancer screening, in the first place. And so with that, I'm going to stop sharing my screen and we're going to start launching into some of our discussion questions that will hopefully expound a little bit more on what the panel found during the construction of this research statement. And so with that, I'm going to launch into the first question. So taking that first topic that I just brought up on the variability and standardized, need for standardizing the reporting of incidental findings, as highlighted in the research statement, there are really no widely accepted standardized definitions for what constitutes a quote unquote significant or potentially significant incidental finding on low-dose CT for lung cancer screening. And so the first question, and we'll start with the lead author on the research statement, Dr. Henderson. What steps do you think need to be taken in order to address this issue?
Thanks, Dr. Kim. I appreciate being here today and talking about our research statement, which really focused on identifying gaps in the data as well as knowledge. So in the area of lung cancer screening and incidental findings, there are lots of gaps. The first, as you mentioned, is really focused on this notion of what is a significant or potentially significant incidental finding. The American College of Radiology did develop lung RADs, which I'm sure you're all familiar with, specifically for lung cancer screening to standardize the reporting as well as the management of lung nodules that are detected on low-dose CT. And in the lung RAD system, radiologists can report clinically significant or potentially clinically significant non-lung cancer incidental findings using the S modifier. The ACR has reported that about 10% of lung cancer screenings have the S modifier included, but several other studies have shown that radiologists may or may not report the incidental finding using the S modifier. Some use the S modifier and specifically indicate actionable follow-up. Others don't use the S modifier, but do make specific recommendations around follow-up for an incidental finding. So it's very challenging to try to use that S modifier as a way to identify either significant or potentially significant findings. So what we really see is a lot of heterogeneity in the way that the lung RADS S modifier is used. So I think that that's one of the big issues is just in that reporting. If we don't have a standardized way of being able to identify the incidental findings, it makes it really difficult to then subsequently go on to determine if they're actionable, not actionable, and what the downstream consequences of those incidental findings are. So I think one of the main things that we really need to do in this space is come up with a consistent definition of what we mean and how we're going to report on it. I think there are several ways that we could do that. The ACR did develop a quick reference guide, and I think that's a good step in the right direction, but I think there is more that could be done. And this is definitely an area in need of more work. Trying to get multiple groups to come to consensus is challenging, but I think it is the direction that we need to go. And I'm happy to have my collaborators also weigh in.
I'm happy to weigh in. Thank you, Louise. And I just want to reiterate that the purpose of the research statements are to really identify the gaps, because that's then how you can devise research questions to address those gaps and possible research methodology in order to conduct the studies necessary to answer those questions. And I think one of the questions that we identified as an important research question is to study or understand facilitators and barriers to radiologists using the S modifier and the ACR recommended quick reference. We just don't really understand, and radiology practices are very heterogeneous in themselves, right? In an academic center, community center, a cardiothoracic radiologist versus a general radiologist. Should there be specific educational opportunities that can be developed through the American College of Radiology, let's say, for radiologists to develop practice tools that can help them improve their interpretation or reporting of S modifiers. So that's an opportunity. Again, we know how well lung rats works for nodules, so it's potentially feasible to think that something similar for incidental findings can be very helpful in clinical practice.
So I'll just chime in briefly. It's really hard to study anything if we don't have definition. And it's very clear that the definition of what belongs in that S modifier category is very variable. And we learned that from the get-go in our own screening programs, as well as with the radiologists who participated in the committee that produced this research statement. So that it's a really common problem in the early days of our screening program. The majority of patients had at least one incidental finding noted. And then the discrepancy between the very strict definitions for nodules, which are algorithmic and incredibly black and white. The contrast of that to the lack of any definition for incidental findings left those of us who were holding those reports and those scans kind of at sea. And so, again, for us to study anything, we need to know what it is that we're studying. There's got to be commonality of definition. And so from the very beginning of this project, it was clear that that is a huge barrier. It's a big problem. And if the majority of patients having low-dose CT lung cancer screening studies have at least one of these findings, we actually really need to address that.
Kathy, I think you're muted.
Sorry about that. I just wanted to say thank you for that from all of our panelists. And now just to go to our next question, we wanted to, so one interesting concept is that was identified in the research statement is whether the incidental findings are expected or unexpected. So for example, should emphysema or coronary artery calcification be considered an incidental finding in a 75-year-old patient with a 100-year smoking history undergoing lung cancer screening? What do each of the panelists think about this topic, and how should it guide our future research in this space?
And we can start with Dr. Rivera for this question.
Absolutely. So I'm one of those individuals who doesn't really believe in expected findings. When you think about individuals who smoke, it's not the majority who develop emphysema, right? It's about 25% of individuals that develop at least physiologic obstructive airways disease measured by PFTs or radiographic evidence of emphysema. The older we are, even with the absence of smoking, there is aging, and emphysema is a part of the aging lung. But I think it's a mistake not to report emphysema. And I think we should be looking at emphysema, we should be looking at the distribution of emphysema, and we should be trying to quantify the severity of emphysema, which in some radiologic reports is very well reported, mild, moderate, paraseptal, central lobular, predominantly in the upper lobes. I think for me as a clinician managing patients undergoing lung cancer screening, it's very helpful. Remember that the U.S. Preventative Services Task Force does not endorse a physiologic testing with PFTs to screen for COPD. So we've got, a large number of patients who smoke who are not undergoing physiologic testing to assess for obstructive airways disease. I think if you see emphysema on a CT scan, even in someone with mild symptoms, that prompts me to justify pulmonary function testing, because I do think that can help in the management of patients who are currently smoking and who might benefit from interventions. So and the same is true for coronary artery. I see this as we should be reporting emphysema, and we should be reporting the degree of emphysema, and the clinician caring for that patient that information can be very helpful in terms of managing a likely comorbidity for this patient.
So I completely agree with that. It was striking to understand that sometimes radiologists weren't reporting out emphysema because it was, quote, expected. When, as Patricia pointed out, not everybody who smokes gets emphysema, and in fact, most people don't. And we've all had the experience that a patient with emphysema is asymptomatic until they're really advanced. And so if there's the opportunity to, I wouldn't say screen, but to identify emphysema when it is present, I don't think that that should not be called out because the patient smokes. Those of us who are fortunate enough to work with dedicated chest radiologists know that sometimes they're actually looking in the charts of patients to see if the patient carries a clinical diagnosis of COPD, and if they do, sometimes they won't report out the emphysema. But we also know that everybody who goes to the hospital who gets given an inhaler leaves the hospital with a diagnosis of COPD, when often that's actually not true. And so I think this distinction between expected and unexpected should actually go away, because emphysema and coronary calcification are two of the most important incidental findings that you can see in this population. And the fact that the prevalence of those diseases is going to be higher shouldn't mean that everybody isn't made aware that they are radiographically present.
I do think, if I may, that it's also important information for patients to have. I mean, we know the data that once you have emphysematous changes, once you have physiologic evidence of obstructive lung disease, individuals who continue to smoke are at increased risk of having a decline in lung function. And I find it useful to be able to show patients that they have emphysematous changes on a CT scan, and to talk about what that can mean in terms of continued smoking. And sometimes I think it may be very helpful to help encourage patients into smoking cessation programs.
Absolutely. I think, you can argue all you want about whether lung cancer screening is that teachable moment, but speaking with the patient about the fact that it increases the risk for more lung disease, continuing to smoke, as well as the risk for lung cancer. This is a motivated population that is getting screening. And if that can help them understand how important it is to quit smoking, that's your moment to share that information.
Anything else you'd like to add, Dr. Henderson?
No, that was a great coverage by Patricia and Lynn.
So bridging off of the teachable moments that we just mentioned, so we're discussing the reporting of these incidental findings on lung cancer screening radiology reports. How do we think the reporting of these findings influences the behavior of the ordering clinician and or the behavior of the patient? Especially if a specific recommendation is not brought to your attention by the reading radiologists. Dr. Tanoue, we could start with you.
Sure. So primary care physicians, who are predominantly the people who are going to be ordering screening studies because it's part of preventive medicine, are already overwhelmed by information. And so I think that more clarity we can give them in the reports, the better, because everything that may be called out by the radiologist that's in the body of the report may not be so important or needing of follow-up. And so I do think that, in fairness to the people who order the scans, the things that are important enough to have, the ordering provider think about follow-up should be called out below the impression line. And so at least to make the report more standardized in that fashion. And I think this comes back to the way that lung RADS is reported out, where the nodule reporting is so clear. Mm-hmm. It's given a category and then a statistic about the likelihood of lung cancer, and then a recommendation for when to get the next imaging study. And if there's an abnormality in terms of the nodule, even a recommendation to consider doing a PET scan or a biopsy. At present, the recommendations for a category S finding may not be called out as category S. We already talked about the, expected, unexpected, and how that may influence reporting, except that, radiologists really haven't been given clear instructions of when to use that expected, unexpected, and I personally feel like it should just go away. But what can we expect of our radiologists? There is the ACR quick guide, and there are all the ACR white papers, and there are guideline statements from all societies who have a stake in the organs that live from the, the neck down to the upper abdomen. That's a lot to expect both the radiologists as well as the providers to be able to manage. They certainly don't have it at their fingertips. From the patient perspective, and obviously this is a big stakeholder group, all of it is scary. And certainly if there is a recommendation made to do something, and they're reading their reports, which I would say more than half of my patients are, their expectation may be that something should get done, or that they see what's described in the body of the report, like coronary calcification, even if it's a spec, and are calling me to ask, do I need a cardiac cath? And, really the need for incidental finding standardization, from my very personal perspective, started the minute we opened our lung cancer screening program, because I spent a whole lot more time talking to patients about their incidental findings than about their nodules, because we prepared them for the nodules during the decision support visit. But, can we really address there may be a million other findings, and we'll deal with them if they show up. And so, again, everybody who's involved in this process is affected by the lack of standardization of reporting. And I think it creates work, it creates anxiety, maybe for all of us. And addressing this process by trying to understand what can be done to improve the reporting out certainly is one of the first steps that we need to understand by more study how best to accomplish that.
I agree. I'm sorry. Didn't mean to.
No,
I
go
think
ahead.
the lack of standardization, the lack of a definition, all right, what is significant enough to report, has been problematic. And for me, I simply think this is a huge area where there are gaps in knowledge. We just don't know how incidental findings impact patients. We can't study it, right? Because we don't, it's just so heterogeneous the way it's reported. We don't know how it impacts clinicians. We can speak about our own experiences. And I agree with Lynn. I spend more time in my lung cancer screening talking about incidental findings than about lung nodules. And that's it's a lot of work. So I'm not quite sure that we really understand what the impact is on the healthcare system, the clinicians, or the patients.
Yeah, and I would just add and say, I think, another issue is that a lot of the data we have on incidental findings comes from, for example, the National Lung Screening Trial. We don't have a great deal of data from large populations in real world practice. And so I think that makes it also difficult to understand. In part, we don't have that data because it would all be collected slightly differently because of the way that there's not standardization for the incidental finding reporting. So before we can get to the point of being able to compile data across multiple different types of settings, systems, populations, having some underlying, systematic way of collecting and standardizing the data is really needed to help inform subsequently okay, now we want to evaluate, what are the benefits of detecting these incidental findings and doing something about them, versus what are the potential harms or burdens. But we can't really get to that point because we're all measuring it differently and in different ways. So just a challenging space.
To that end, I'd like to actually shift gears now, moving more from, we've just had a great, robust discussion regarding, how incidental findings are currently reported and, the lack thereof of standardization. But moving on to sort of the potential consequences of what that reporting might mean downstream for our patients, let's move now on to the second topic of management of incidental findings. And so I'd like to kick off this discussion with really focusing on the potential downstream diagnostic testing that may or may not be recommended by clinicians as a result of incidental findings being reported. So there's already been quite a bit published in the literature regarding sort of the potential harms of lung cancer screening, in general. And specifically, since 2014, CMS has continuously required that shared decision-making be performed and documented prior to initiation of lung cancer screening. Integrating now the kind of additional complexity of now taking into consideration incidental findings, how do you discuss the possibility of harms associated with diagnostic evaluation for incidental findings as part of this shared decision-making process, if at all? And, from a research perspective, how do you think this question should best kind of be addressed as we move forward to try to elucidate what to do with these incidental findings? And I think for this question, we're back to starting with Dr. Henderson.
Sure. So I do think that as part of the shared decision-making process, it's important to let patients know, there is the likelihood that, there may be an incidental finding detected. I think it was Lynn who mentioned earlier that, a lot more of her patients have incidental findings than maybe nodules. And so I think to some extent, preparing the patient and just letting them know, there may be an incidental finding reported. It may be something that we need to act on. It may not be. I think having that as part of the conversation is important as we think about the benefits of screening versus the harms of screening. I think right now we don't know for those incidental findings, depending on what they are, how that may tilt really the balance towards beneficial versus is it something that, may not be. And I think a lot of it also depends on the patient. Different patients react very differently, depending on their, underlying lived experiences. And so I think it is important to think about how should we incorporate the incidental findings into that shared decision-making process. But I think we really need studies to ask patients how would they like that information communicated. Do they want a provider to call them and talk to them? Do they want to read about it in my chart? So I think there's a lot that we don't know. And in our research statement, we really tried to highlight some of the questions that we thought as a group were most important in this space in terms of where we really do need additional research. And we do have several questions that are focused on the patient. And I think the shared decision-making component would really help to get at that space as well.
I just want to echo that I do think it's important to conduct within the shared decision-making discussion, but it is time-consuming. And when you have, 15, 20 minutes, and seeing a patient for lung cancer screening, often 15 minutes, it's very difficult. One of the things that I have recently adapted is the very nice figure from our research statement. I don't know if you recall figure 1, that really identifies all the potential organs where an incidental finding can be found. So I've actually incorporated that figure into the after visit summary for patients. Just as a reminder, I talk about the cardiac, I talk about lung, and I talk about thyroid nodules, which are the most common. But I basically tell patients that in every organ that is captured on the CT from the neck to the upper abdomen, I think this is a nice figure. Now, some of the words are complex, but it's helpful for patients to say, oh, okay, and then, it's important to relay the information in a way that is understandable to patients. I just want to go back to an issue about harms, and we focus a lot on the harms of incidental findings, but I am not sure that the data supports that the harms of identifying incidental findings outweigh the benefits. And I do think that it's important for us to be thinking about it in a more balanced way. Identifying some incidental findings and acting upon them can be extremely beneficial for patients. The coronary artery disease, where patients have not been properly evaluated for hyperlipidemia or hypercholesterolemia, or their blood pressure isn't controlled. The pulmonary hypertension, bronchiectasis. So I'm really in the camp of there's a balance, and the benefits may be as real as the potential harms of incidental finding management. And I think it all boils down to how they're reported and what guidance is given to clinicians about appropriate follow-up for incidental findings.
I completely agree with that. It would be impossible to walk a patient through the likelihood that an adrenal nodule, a thyroid nodule, an ectatic aorta, all of those things is going to be for them. We're really still should be focusing on the lung cancer risk, and that this is being done for lung cancer, because burdening a patient with huge amounts of information about other things that may be present in a minority of them probably doesn't actually help. That by itself would be worth studying, right? But I really think a simple statement of lung cancer screening is different than breast, colon, and prostate cancer screening, because it's not organ specific. We're going to get these beautiful pictures of your entire chest from the neck to the upper abdomen, and we are going to see those other organs. There may or may not be anything that is important, but whatever's there will be reported out. You'll see that if you read your report. Try not to be overwhelmed by that amount of information. The focus is still on your lungs and your lung cancer risk. And if there are other findings, we will discuss them afterward, or your doctor will discuss them with you. Again, it points out the importance of standardization, so that when the patients do get all that information, or the ordering provider gets all that information, there's some sort of sorting mechanism to point out what's important and what's not. This even comes down to what is the language that's being used. And so calling something an aortic aneurysm because it's slightly dilated is actually not correct ACR terminology. And yet I see that all the time. An aneurysm is a word that many patients recognize as if that bursts in your brain, you'll die, and so it's a scary term. Ectasia, they might have to look up, but at least they get a definition that way if they choose to look up that information on their own. So again, the standardization of language, the introduction of the concept that we are actually looking at your entire chest and all the organs inside. I agree with Patricia that might be a good thing. People want that whole body scan. Not sure why, but that's, touted as such a good thing. You are getting this information in addition to the information about whether or not there's something there that's concerning for lung cancer. So I would say the framing of that negatively is probably not a service to anybody. If we can standardize the language and get the definitions right, it should actually be beneficial.
Thank you very much. It's very helpful from all of you regarding this. And just sort of a related question. So oftentimes the low-dose CTs that we get have these incidental findings that you're talking about. Do you have any concern in terms of the fact that it is a low-dose CT, and could this compromise the radiologist's ability to accurately make those diagnoses? And then related to that, one of the questions that radiologists often have is when they're giving their follow-up recommendations, do you recommend that the follow-up for the incidental findings, if it's a CT, is a low dose CT, or do you think that that should be a full dose CT? It's something argued in radiology department, so we'd love to hear your input on the on what you think about it.
So I'm not going to comment on full dose, low dose, because I think the radiologists know what the right scan is, right? That right imaging study would be for an incidental finding that's that merits more follow-up. And so, an adrenal nodule is going to be hard to really evaluate on a low dose CT scan. But if it's large enough, the white paper from the ACR for management of adrenal abnormalities calls out what the appropriate scan is, which in some cases is going to be an MR, right? And I think this is, it really reinforces this need for the radiologists to have references that are easy and reliable. Recognize that the white papers that ACR has published weren't developed for a lung cancer screening population, therefore the general population. And we don't have a way, this is another gap of knowing whether the recommendations of the white papers are really applicable in a high-risk lung cancer population, right? But that's what we've got right now. But even the ACR quick guide is not so quick. If you've got 5 incidental findings, you have to look in 5 different places. Are you going to make 5 different recommendations? And if there is real concern about any organ, including the lung, you often are going to need just a higher quality study. And I think that's fine, because the original study was done to minimize the radiation without losing all the quality of the images. So it's good enough for the purpose that it was done for. It may not be good enough, that approach with low dose, for other things. And often I think it's not. But again, we've got to give people guidance about that. And what is the best way of doing that? Well, first we have to get the radiologist to report out consistently, and what's the best way of doing that?
I think for me, the recommended follow-up imaging for incidental findings depends on the incidental finding. If you have an incidental finding that it suggests interstitial lung disease or fibrotic changes, if follow-up low-dose CT is not the diagnostic test, it should be a high-resolution CT scan, with prone and supine imaging, inspiration and expiration. If you have a nodule that might be suspicious for an arterial venous malformation, it's not a low-dose CT, it's a CT angiogram. So I find, again, because I think we do see a lot more incidental findings. For example, steatosis is called out a lot. And then it's, mild, moderate. I wouldn't get repeat imaging for that. I make sure that the patient has been evaluated by their primary care physicians. Do they have liver function tests? Do they have other, screening studies that need to be done for liver disease? But I think it really depends on what the incidental finding is. And, if it's a ground glass nodule, that's going to be a lung rat's recommendation. If it's multiple ground glass nodules or an atoll sign, because you think somebody may have cryptogenic organizing pneumonia, you don't need a contrast CT to follow that. So I think it really depends on what it is that's being reported. And I agree with Lynn 100%. The radiologists are really good at guiding, at least when they say abdominal findings, what should be the next step, right? It should be consider abdominal CT with contrast, consider abdominal MRI. So I do think it's important to have the recommended study be aligned with the actual incidental finding.
Dr. Henderson, anything else to add?
No, nothing further.
Okay, great. A little bit of radiologist perspective for this next question for our panelists. So low-dose CT for lung cancer screening is a non-ECG gated examination, non-contrast. So it's subject to cardiac motion artifact. Our ACR guidelines recommend a subjective assessment for coronary artery calcification on all of these screening exams, and for us to report them as none, mild, moderate, or severe. And if present to any degree, they want us to recommend a primary care provider assessment for atherosclerotic cardiovascular risk. Often, we don't have any prior imaging on the patient or know much at all about their clinical history, including their cardiac history. So do you think this recommendation for follow-up is appropriate? And if not, how can we optimize this? And we could start with Dr. Tanoue again.
So could you clarify what ACR is recommending that you do when you see coronary calcification? Is it stratified by severity?
Yes, so it's a subjective assessment. So we're just looking at the image and we're putting it into 4 categories: no coronary artery calcium, mild, moderate, or severe.
And when are you recommending that there be potential cardiac evaluation to the ordering provider?
This is part of the problem because it's very variable. On the ACR guidelines, it says if present, if coronary artery calcification is present, recommend PCP assessment. But then there's some subtleties like, was this present on prior imaging? If it's known, we don't necessarily have to report it. But for example, if it's progressed significantly, we should report it. But again, I think this goes back to why we need more standardization.
So I'm really glad there are 2 radiologists on this call. When we looked at our first 150 scans, 90% of them had coronary calcium identified. And when I looked at the scans with a radiologist, sometimes it was a speck, right? Like really mild. And we know that radiologists who are trained in the methodology of, count the segments that are calcified, if you do that often enough, you can actually call out that mild, moderate, severe pretty easily without it taking a lot of time. And really, who should you be calling out below the line, below the impression line, recommend cardiac evaluation, because patients are reading them, right? And I would argue that, the yield of doing further cardiac testing, if there is mild coronary calcification, is low. And I think that that's known. Whereas the yield with severe, multi-segment coronary calcification or entire vessels that are calcified is high. And so if there is going to be a stratification of none, mild, moderate, severe, I think the threshold at which further recommendation to do more evaluation should not be just because it's present. Mm-hmm. It should be stratified so that the right patients get more evaluations, and most patients won't, except that they know that now that there is calcification, it's called out in the body of the report, and it should then trigger the primary care physician to do the things Patricia already called out. Check the lipids, check the blood pressure, make sure that the normal preventive interventions for a middle-aged person to look for coronary disease are done. And so again, there's so much that needs study. And this is a big area, which is why we landed on it as kind of a call out of the incidental finding, the coronary artery calcification. But if 90% of patients who smoked enough to get lung cancer screening have some calcium, I really don't think that that's reasonable to throw that back at the primary care providers or the ordering physicians or the patients that go figure this out, right? You already are doing the stratification. I think that would be very helpful for ACR to determine where the threshold should be to pull that out below the impression line so that everybody who has a stake in that is aware. I can tell you that because it's so common and patients are afraid of having heart attack, right? That I don't want to drop dead because I have a quote widowmaker lesion. That cardiology is so embedded in kind of everyday life that patients are very aware of the consequences of having a myocardial infarction or cardiomyopathy. So that the anxiety level of patients has to be taken into consideration in terms of how the reports are generated, and standardizing that would go a long way to helping the ordering providers know what they should do next, and alleviating patients' anxiety. So this is, again, risk benefit. What would be the harm? The harm would be if every patient with a speck of calcium goes out and gets a stress test and a cardiac cath. The benefit would be if you can find the patients who, even though it's expected because of the smoking, would benefit from cardiac intervention. That would be a huge win. So, focus on the patients who will get benefit and try not to hurt the people who are not going to get the benefit.
I agree. I want to make a comment that if there is coronary artery calcification, I fully endorse a method to stratify the severity, because it's very helpful to me as a clinician when I read mild, moderate to severe. I also think it's imperative that radiologic reports be consistent. If there was coronary artery calcification in the 2024 low-dose CT, and it's again present, and because it doesn't go away on its own, it should be mentioned. Coronary artery calcification present, unchanged. Importantly, progressed, right? I think that's really, just because it was called out a year ago, it doesn't mean we should leave it out of the report. And I do think that it is critically important to know the degree of coronary artery calcification, because then for me, it's, does this patient have known hypertension? Have they had their, lipids and cholesterol checked? Are they on a statin? Is their blood pressure well maintained? And I find it very useful to reconnect with primary care physicians to ensure, hey, when was the last time the patient was seen for a blood pressure check? Are we sure they're on adequate medications? I think we do a disservice, as Lynn points out, if we're recommending a cardiac evaluation for any degree of calcification for mild. I don't think that's appropriate utilization of healthcare resources. Not calling it out may potentially be a harm by not identifying a treatable comorbidity.
Right, and not calling it out because expected,
Right.
I think is a mistake.
Right. And I think one other gap related to that is, if it is documented in the radiology report and the patient reads the radiology report, to what extent would that, mean that the patient might say, oh, I do have something heart related, so maybe I need to talk to a cardiologist about statins, or I need to talk to someone else. And so the extent to which it could also drive the patients to seek additional evaluation for something that is treatable, is another area that we identified as a gap. And I think it goes back to this issue of, how do you talk to patients about incidental findings, and how, as we mentioned earlier with the shared decision making, to some extent, there are patients who would never look at their, medical records, but there are patients at the other end of the spectrum who do go in and read, everything, and who may then act on it in a way that would end up being beneficial. So I think there is a lot of variability in patients as well.
What a robust and excellent discussion. We're rapidly coming to the end of the hour here, but I do have one perhaps final question that I think might summarize some of the things that have been brought up by the panelists over the course of this discussion. And one of the things I really loved in the way that the research statement was organized was looking at some of the different subsections from different stakeholder perspectives. And Dr. Henderson just brought up a very important, stakeholder perspective, which has come up a couple of times, which is, of course, that of the patient. And I was actually just at a talk recently where one of the audience members actually divided his personal clinical practice into before and after patients had access to their radiology reports, which I think Dr. Tanoue brought up earlier as well. And the question I have, and also trying to integrate the wonderful question we got into the from the chat from Dr. Duvall, is if we start incorporating, like Dr. Rivera just mentioned, maybe some sort of different stratification or some sort of at least qualitative, if not quantitative, risk assessment regarding whatever incidental finding is found by the radiologist in the report, given that patients are frequently looking at their reports even before we have a chance to look at it as clinicians. I guess I wonder what everyone's thoughts are on how best that can be studied, and what kind of further research questions might be coming from exploring more of the patient perspective. And I think for this question, we are actually back to Dr. Henderson.
Yeah, so I think thinking about how the patients are going to receive the information and potentially act on it are very important. I do think we need to remember it's lung screening for lung cancer. And so, that is the main reason for the scan. And so in that shared decision-making conversation, obviously that's the main focus, but I agree with what Lynn had mentioned earlier with at least making patients aware that, this is different than other screening modalities in that, we're scanning a much larger area and there is the potential for, something else to be found. I think we don't know, and this is highlighted in the research statement, how patients would react to or perceive, news of an incidental finding when they came in thinking I'm getting screened for lung cancer. And so I think there are lots of areas of potential work in this space. I think it would really require working directly with, patient groups, either doing qualitative interviews to ask them about preferences or, doing focus group type activities. But I definitely think that it is a space in need of further work and something that, I'm hopeful that there's so many topics that, others who have expertise in this space will kind of take on and really help us to generate evidence on what do patients want, because I think it is such an important perspective.
And I think you asked, Roger, about risk stratification for incidental findings. And I think that's difficult to do. The radiologists have already so much that, they have to do when they read, it's not about the nodules, but now they have to report, and we want them to try to report with consistency the incidental findings. Unless they have the time to go into Epic and get an assessment of the patient's age, smoking history, hyperlipidemia, hypercholesterolemia, they're not going to be able to, assess in terms of risk. This patient is at high risk for an MI, or this patient is at high risk. I think that's something that can be done post low dose CT if we have better definition of what is a significant incidental finding, better standardization of the reporting and the recommendation. I work very closely with primary care physicians. I couldn't possibly manage the incidental findings that are detected in the screening program. I simply don't have the bandwidth nor the knowledge. I really rely a lot on the primary care clinicians to take the lead. And it really works very well. I feel very comfortable when it's pulmonary hypertension or bronchiectasis or ILD. I don't feel comfortable when it's GI findings and, what is the best test to do. I think that's really a multidisciplinary, often, ordering clinician and primary care physician, ordering clinician and reading radiologist, but it's hard to risk stratify before the low dose CT.
So just a couple of comments. We did a little study where we took our reports for low dose CTs before we had standardized the incidental findings, and then showed them to primary care providers. So they had the before, the standardization, and after. And was what the primary care provider decided to do for any number of incidental findings consistent with guidelines. And when the radiologists had standardized their recommendations based on the ACR white papers, the primary care providers ordered guideline consistent care much more often. They could choose to do something else than what the radiologist said. But it was a very small study. It was wildly statistically significant that made a difference. From the patient perspective, all of us have probably seen Chris Slator's article, "What the heck is a lung nodule?" It's this great, qualitative survey. I think there were 17 or 19 people involved, patients involved. And I remember at the time thinking, wow, I would never send a patient a written report that had a nodule on it and expect them to deal with that, except that's what's happening now, right? I'm not sending them. They're in Epic, they're in our EHRs, and so the patients are receiving them, not from me, but just because, and Roger, as you pointed out, they get told there's a scan report waiting. I don't get told that. I just have to look in the EHR, right? So they often know before me. And I think about Chris's article that for all of these incidental findings, that's kind of where we're at. What the heck is this other nodule in my thyroid or adrenal, or the fact that my aorta is a little bigger, and what is interstitial lung disease? And so for all of those things, there is this probably mystery to the patients, which again creates stress and anxiety, and whatever we can do to try to alleviate that. I think we need to know what that is. What can we do to mitigate that? And then we need to try to implement.
With that, we are already at the top of the hour. It's amazing how fast time flies when we're all talking about something that we're all so passionate about. With that, I really want to thank Doctors Henderson, Rivera, and Tanoue for joining us today. And thank you, of course, to my co-moderators, Dr. Scalabrino and Dr. Capaccione, for a wonderful discussion. As a reminder, this will be posted onto both, correct me if I'm wrong, Samantha, but both our ATS website and our brand new ATS YouTube channel, and which are organized by Assembly. And if you want to look at any of our previous webinars that we've done over the past number of years within our Thoracic Oncology Assembly, I believe there's actually a dedicated playlist for all thoracic oncology related topics, of which we have covered several over the past couple years. And so thank you, of course, to all of our audience members as well for joining this wonderful discussion. And remember to tune into the recording and share widely to anyone who you think may find this discussion beneficial. And thanks very much, everyone.
Thank you. Thank
Thank
you,
you.
Rebecca.
Thank you.
Bye-bye.